guys, I want to welcome you guys all to the first IEMED live event. What we're doing here is we are creating monthly vlogs, essentially, where we have guest speakers come on the IEMED live channel. And what we're going to do is we're going to capture those. We're going to have some great educational discussions about any of the topics within the industry. And afterwards, we're going to place this in the CME Collective so you guys can get these this content and information for free. It isn't no cost to you. There's also an annual subscription. If you guys want to get the continuing education hours, you can. But once again, we want to provide free access to online medical education. And that's where we put it. So we put everything in the CME Collective. You can view anything in the CME Collective for free. It takes like-minded individuals, reputable content, industry-leading content. It puts it all in one space to make it easy for you, the student, to find and get the information that you guys are really needing to do your job. So I want to welcome you guys all to Peter Antevy. Dr. Antevy, thank you so much for being on our first episode of IEMED Live.
Chris, hey, great to be here, man. Thanks for having me on. A privilege to be the first one.
Yeah, I know. It's a very exciting moment for us. You know, we've been trying to do this for a while now. And so to finally get to this event and link up with you, has been definitely an honor for someone who's been following you and see what you've been doing with the EMS and pre-hospital community, with pediatrics. I mean, you are definitely a champion of what you guys are doing out there. And I sincerely appreciate that from the line guys' perspective. So thank you guys.
Thank you. No, it's nice to be a pediatric ER doc by training who then infiltrates into EMS. So now they have no choice but to have me in EMS, and it's really been a win-win for me as well. My career has been amazing ever since I got into EMS. So,
well, it looks like they're kind of stuck with you now, right?
You're stuck forever.
Which is good. I mean, we need progressive thinking. We need change. So, and that leads us to kind of what we're going to discuss on the first episode of IEMED Live. So we're going to kind of go into a little bit of the pediatrics. As we're coming up into the winter seasons, we know that pediatric airways can kind of be problematic. So what we're going to talk about is a little bit about bronchiolitis, croup, epiglottitis, and then we'll talk about some of the management and more specifically the airway management and some of the things that you guys might be able to consider, whether you're back in the ambulance, at a scene, in a facility, or on a transport, and how it can hopefully, benefit you. We're going to round that out with just some critical, pediatric transport pearls, some documentation and charting needs that you might want to hit, check those boxes, and then we'll wrap up with just some general pediatric transport considerations. So, Dr. Antevy, when it comes to bronchiolitis, bronchitis, as we're coming into this RSV season, what are some typical signs and symptoms that you see that, it would be easy and astute for, maybe just a general medical provider to pick up?
It's a great question. I think that most providers need to understand that this is the season, as you said, but that first initial walking into the room or into the hospital, wherever you're picking this kid up from, before you get up to this kid and you scare the heck out of this kid, you really have to make a good assessment. And I think people fail to recognize that pediatric assessment is really often made the best from far away. Huge, right?
Hands off. I mean, that was one of the first things I got taught early on by my preceptor go through paramedic school. When I walked into my first, it was actually, I think, a croup patient or an epiglottitis. I can't remember, but I remember it scared the crap out of me. But I walked in, and the first thing I'm trying to do is get right next to the patient. And he's like, stand back. Let mom help. Don't, make the kid anxious. Go right for breath sounds. So that's a very good point.
It's huge. And then the kid, if they're a little older, will look at the mom and see if how the mom is jiving with you. And then if the mom is okay with you, then all of a sudden the kid looks better. So you really have to, I think the entry into the room, I think any room, right? And we talk about this in my EMS systems all the time, is how do you make that introduction is you really have to kind of come in, stay back a little bit, introduce yourself to the parent. And if the kid's old enough, introduce yourself to the kid, stay back and then look. And you're looking at, the classic PAT, right? And you're looking at airway, breathing, circulation.
I love that triangle, man. It's down, dirty, simple. That's what we teach in our courses because it's simplistic. You can observe from across the room, is this kid sick or not sick? And should I really care, or do I have a little bit of minute to kind of secure my reputation with both mom and patient and then move forward from there?
Well, it's interesting you say that because if you have a kid with croup or epiglottitis, somebody who's end tidal, if you had an end tidal measure on them or their PCO2, is now already up in the, let's say the 45, 50, then 55, and they're kind of, let's say they had a little stridor coming in, let's say they're tripoding a little bit, and then you come in and your team comes in and you kind of like overwhelm them,
Overbear them.
overbear them, and now this obstructive disease gets worse, and now their end tidal goes up and up and up, and then all of a sudden this child starts to become altered, and next thing you know, you're coming in, it's a code, and I've been there. By the way, I did that in my younger years, and so we can actively make things worse in our profession, especially with these young kids. So with bronchiolitis, these are obviously the kids who are under a year of age. The ones you have to worry about are they preemie? Do they have a cardiac history at all? Is there any history of wheezing in the past? Have they been admitted to the ICU in the past? But you have to be able to come in and immediately detect sick or not sick. And then once you kind of, if the kid's sick, you're coming right in and you're going to work. But if not, you really should kind of take a step back and do, appearance. How does the kid appear to you? Work of breathing, circulation, you could do all that. And then you want to get in, and as you're doing that, your mind is going through, what are the first things I need to do for this child? And oftentimes people forget the basics when they're talking. They want to go right to a medication or something more
leads on, or like, hey, how can I irritate this kid the most, right?
Yeah,
and that's what it seems like to me, because I used to do that until I learned, like, hey, that's probably not a good idea. Maybe I step back, take a minute, take another glove out, make a little balloon glove, draw some little smiley eyes and go, hey, how are you doing today? And then lead into my.
Well, it's just like a kid, let's say, who has anaphylaxis, is on the mom's lap, okay? So the kid's sitting on the mom's lap, the kid's wheezing, he's got hives, he's got swollen lips and tongue, and all of a sudden you want to come and like take that kid away. Well, if the kid's on the mom's lap, and you can do epi, Benadryl, salmeterol, albuterol, right? Boom, boom, boom in a row. Mom still has the kid on them. Throw some O2 on there, and then the next thing you know, you can do another IM epi if you need to, and then you can start an IV. So like, you don't have to like pull the kid away from the mom, and all of a sudden the kid goes berserk. So oftentimes we want to treat those kids where we find them. So it's all situational, right? If you haven't been in that situation. Another one is Croup, where the kid who has Croup kind of needs to be in a position that's normal so that they can actually keep that airway open. You want to keep them calm. The minute you piss them off or you mess with them, that kid's going to start to go downhill on you fast.
And I've been there where, we were a little bit overly aggressive maybe. And once again, I think you mentioned this probably comes from clinical experience. You have to put yourself in that situation to really appreciate that environment moving forward. And I remember kind of going in there and kind of disturbing the kid a little bit too much. And exactly like you mentioned, is our habit of, hey, kid looks sick to me. I don't have a lot of pediatric experience as a firefighter, paramedic, or a new paramedic, or a new nurse, new flight nurse. And what you want to do is you want to control the situation, right? And you feel like you control the situation by taking kid away from mom, which is probably in my hindsight, probably the worst thing I could have done. And by causing that kid to get all anxious. Now he's crying because I took him away from mom. And it wasn't that long after that you just saw him become blue, and now we're leading into an airway. It led right into a pediatric code arrest. Luckily, the kid had a good outcome, but it was a very good teaching and learning moment at the same time.
Yeah, I think that those are all great points. And if someone's listening here who is not that experienced, to understand that, just stand back, observe, understand what you're going to do next. For those people who are very experienced, I'm sure that we all have that Rolodex of kids that we kind of went the wrong way because we just approached the patient the wrong way. So I think that's just a basic thing. Moving on to the physiology of bronchiolitis, obviously there's mucus filling up in the lower airway. This is basically many times just require a little bit of oxygen, some suctioning. Back in the days, we used to use albuterol, but we don't do that anymore. We use 3% saline, and that breaks things up. I love using, and there's some people who don't agree with this, but some racemic epinephrine, or just straight up Ep.01 to 1000 and nebulize that. And that'll kind of help open up the airway as well. And I think, obviously for those who have high flow nasal cannula, that's been an amazing thing, right, for kids who have bronchiolitis. And then obviously when you keep going further down there, then you have the kids who are tiring out. because they just can't keep up. They're young. Their metabolic rate has been going on for quite a while, and now they're not breathing as fast. Their end tidal is going up, and now you have to kind of step in and then take control of the airway. So I think it's very basic, but you have to know how to do the basics before you get to the more complex part.
You got to be able to walk before you run. And I think that's sometimes what we like to do is just run. And I'm just going to go to the end effect because once again, the confidence isn't there. And obviously confidence comes with training, education, and clinical experience. I think you hit on a very good point though, that is not very common out there right now. The 3% saline to help break things up. I love how you brought that up. Can you expand on that just a little bit more?
Yeah, so there's studies, remember, for many years, we would flood these kids with albuterol. So it didn't matter if you were an asthmatic or not asthmatic, but like we had all these kids getting albuterol, and here we are in the emergency department where now this kid's, let's say, 2 or 3 months old, and they don't have a nebulizer. So now 2 o'clock in the morning, I have to get them a nebulizer. Then people start saying, well, let's just give them an inhaler with a mask, and are they too young for that? Long story short, we recognize, and these are studies that were done at large children's hospitals, that just the concentrated saline was enough to go in there, break up the mucus, and allow them to either cough it out or to help us suction it out better. But essentially, it's just kind of that saline just helps open up that airway without the need for albuterol. And then at my children's hospital, what we do now is, because this suctioning is the most important thing you can do, right? We have kids who are not looking well at all. Next thing you know, we suction them and they look like $1 million. But what's going to happen in 2 hours from now?
I love how you pointed it out. So first off, albuterol, that's probably, no joke, still the first line treatment for a majority of us in the pre-hospital environment who are, it's still in all the protocols. It's, hey, first kid has a problem breathing, great. I'm going to slap them with some albuterol, start an IV, make them all irritated, and then here you go, ER. Thank you.
Correct. But
you mentioned deep suctioning. Suctioning, I learned after the fact when I started flying neonates how important suctioning really is. It'll change your entire transport. Just by prepping yourself up and doing some deep suctioning beforehand, I don't ever have a problem during the flight, most of the time, knock on wood.
Yeah.
But how do you prefer to do that suctioning after you've either given the 3%, or you just need to get that out and help that kid kind of move that junk out?
Well, I think it's a great question. These are mucus plugs that are occurring, and so the kid who's looking well, who's now not looking well, it's a mucus plug. So what we do, have you ever seen those nasal olives?
No, I can't say I have.
It's basically, it looks like a little olive that kind of goes into the nose. It doesn't go into the nose. It just kind of covers the entire nose. So you have just like a little suction. It's basically this big. You hold it up here. You put the saline in this side, and then it goes all the way in and out the other side.
It's like a mechanical neti pot.
It's exactly right. We're not going deep. We're not going deep now on the kids who are sicker, who we can't get that out. We will put the saline and we'll go all the way deep and we'll get that, but we almost never have to do that. So it's called a nasal olive. It's a great thing. There's no going through. The kids hate it, but then they get up and they can breathe again. So we're talking about the little ones here, the kids under a year of age.
Yeah, and that's important, because I would actually see their sats change, whether they're on a vent already tubed or not. When you would suction them out afterwards, it seemed like their anxiety went down because they could breathe better. So they didn't have that like anoxic kind of anxiety effect, which leads into that tachycardia, which leads into more O2 burn, which, it's kind of like a spiraling kind of repetitive circle. And if we could break that with just some routine suctioning where, once again, I think coming back to my own clinical practice, I didn't know. I didn't know how to do it appropriately. I didn't know what resources it was. I didn't know how important it was. Everybody talks about suction. I'm like, we'll get by until we get to the hospital. But now I'm like, no, we're not even going to move until we do a little bit of suctioning, because I found that they tend to trend better if we kind of do that early on and set ourselves up for success.
It's something like that. You just gave me a great idea. Maybe I'll even put out a quick little video on how to use the nasal olive, because it's so simple. And if you don't do it right and you have a mucus plug that you haven't gotten out, then guess what? Now you're going to have a kid who's going to end up, you can't oxygenate, you can't ventilate, and now you're going to end up doing, having to either intubate or do what have you. And that's when things start to go wrong. When you didn't have to go there, first do no harm.
Yeah, you didn't have to go there, but you got pushed into there either from lack of training, knowledge, whatever,
Correct.
or just lack of or just a happenstance of unfortunate circumstances. But
Yep.
it does. You don't want to get in that situation. It's not a good situation to be. I've had a couple of needle cracks in my career, and none of them had a good outcome, to tell you the truth. So,
Correct.
at the end of the
Once
day,
you're doing yeah.
what can we do to avoid even getting to that point in the first place? So, no, I think that's a great idea. Please let me know when you share that. We'd love to share that on our channel, because
I definitely
it's
will.
little things like that really, when you come back down to it, people understand what suction is, the theory behind it. It's when it actually comes down to doing, and how can we best perform this procedure in the back of the ambulance, at the scene, at the patient's house, in their crib, and in mom's rocking chair. Those are the situations that we don't get trained for. And
Yep.
that's where having discussions like this really kind of hopefully will help those guys out.
Yeah.
And girls, don't forget the girls out there.
I totally agree. So just to recap, we're giving them oxygen. It brings down their heart rate. It actually brings down their metabolic rate. You're doing a good suction. So when those kids come into my emergency department, first thing we're doing is oxygen, and we're suctioning. My respiratory therapist is first, right? And then we're starting an IV, because these kids are always dehydrated. And we're giving them a nice bolus of 20 per kilo of IV fluids. And maybe we're doing an X-ray, maybe we're doing a swab to check for whatever they have. But for the most part, if a kid comes in who's kind of on the moderate scale, who's not like dirt sick, you can turn them around pretty quickly before you end up getting to the point where you're now bagging them, and then potentially even putting an oral airway, and then maybe even intubating them. But again, before you even do that, in my emergency department, we're using high flow nasal cannula to great benefit. Now, not many EMS agencies are carrying that. So just a quick word on high flow nasal cannula.
Yes, please.
Right. It's not just taking your current, nasal prongs and turning it to flush. That doesn't work that way, because if I took this non-humidified air and blasted into your nostrils, it's very irritating. Nobody likes it. So with high flow nasal cannula, you can get, something like, 40 liters a minute, very high flow. It's humidified, and it actually is tolerated pretty well by these kids. So these kids in the ER, they start with it. They go to the ICU, and the kids we used to intubate, Chris, not anymore. So it's been
falling out of my practice too. And I think, and I don't have access to high flow nasal cannula. I do have the nasal prongs I've been using to increase, concentration and passive oxygenation as well. And a lot of agencies out there don't have access to high flow nasal cannula. And you're right, humidified 40 to 60 liters per minute. I mean, it's an amazing technology. It just hasn't transplanted over to the pre-hospital environment. What can those guys who do not have access to that high flow nasal cannula, what do you think is the best oxygen therapy that they can provide?
I think
still the old-fashioned, non-rebreather.
Non-rebreather.
Yeah, non-rebreather.
Some kids
don't need
any
success with. I mean, I know you said don't ram anything back, but have you had any success with using those standard pediatric nasal prongs in conjunction humidified sterile water to do that flow?
I think that those kids who are kind of starting to become sleepy and out of it, and they're not really fussing a lot, and you're putting on the nasal cannula and you're turning up the pressure there, I think that's okay, because it's going to irritate them. They're going to keep on breathing. But once that kid starts to spiral down, end title's going up, they're getting very tired, and you're at that point, then you're moving to advanced airway stuff with potentially BVM. And I think that people need to recognize having an end tidal, understanding what your end title's at, seeing the work of breathing, knowing the age of the kid. Are they tiring out? Just so you don't just say, oh, that kid's just tired. It's 2 o'clock in the morning, but their end title's 70, 80, and you're not there assisting them. That's a mistake as well. So I think that, situational awareness, understanding what these kids kind of look like, and not to convince yourself that, oh, it's just late at night and that's why the kid's eyes are closed. I've made that mistake too.
I think we've all been there, and it's very easy to miss like the subtle seizures. It's very easy to miss the altered LC due to hypoxia. You don't catch up on it. You're like, maybe they're just waking up, or they're groggy or something like that. And you're like, it's not until after the fact you're like, No, they were just really hypoxic and circling the drain, and their end tiles, pushing 70 at this point.
Correct. You have to be an astute clinician in pediatrics. You have to kind of look at the kid. And just a quick point on looking at the kid. And I just put a video on this up about maybe 2 months ago. I call it the Blink assessment. It turns out that Malcolm Gladwell wrote a book called Blink.
Okay.
And he talks about how people make judgments. Like when you walk into a room or a hospital room, you're just looking at people and you can tell automatically what's going on with them. And it turns out that if your stress level is way up here, the one thing you're not doing is looking at people in the eyes. It turns out that when you're out of the normal stress level, you're so out of it that you're kind of looking away. The only way to assess these kids the right way, you got to look at them right here. And so you have to kind of be in a zone. You have to be in a zone, like this clinical zone, your assessment zone, because people just don't know how to make an assessment because they just think I'm going to follow a protocol rather than just looking at the kid. Look at the nose, look at the mouth, look at their chest, lift up their shirt, for God's sakes. Take a
Right.
look at how they're breathing. People make that mistake all the time. Look at their color, look at their cap refill, feel for a pulse. Like, do the full evaluation. In pediatrics, it's so important.
I think a lot of people, and I don't want to put words in anybody's mouth, but I'll just take it on me. I'll be honest. When I used to walk into Pediatric Airways as a new medical provider, pediatrics scared the crap out of me. One, I was 21-year-old paramedic. I had no kids. I had never been around kids. Anything I've been taught with kids was either through those very small clinical rotations I did at the primary children's here in Utah, or just by happenstance or reading through material. So I can tell you that me going in for the first couple of times, it was hard to do an assessment, especially on a sick kid, because what do? Your wheels start coming off rather quickly. I don't have the training and the educational experience and that confidence behind me to help bolster when the wheels start spinning and go, hey, how do I get back on track? And so I think you find providers more often or not kind of run once again and get to that whole, I'm just going to go right to a BVM and try to, instead of think clinically through this and go, take a step back. I know the wheels are coming off, but that is the difference between, a clinical professional and, someone who's new to the industry, So
Very, very, very
I
true.
think you made a very good point there.
Yeah, awesome. I think that it just takes some time. You really have to dedicate yourself to training the right way, and just get in front of as many kids as you can. Do shifts at the hospital. Go down to the emergency department. Go to the ICU. You kind of have to be able to see those kids, especially in the pre-hospital environment where we don't have the ability to kind of be saturated with that, and it's kind of a one-off, right? Peds are 10% of all of our call volume. So how do you get to a point where you're comfortable in that sense?
Low volume, high acuity,
Low
and
volume,
when
high
they're
acuity.
sick, I mean, they're sick.
Right. So we now, in the course that we created, we purposely say that you have to think of kids like adults to be successful, because it's all about bringing your stress level to a normal area.
I
If
like
you look
that.
at all of our protocols, SVT, seizure, cardiac arrest, you name it, the protocols are the same except for symptomatic bradycardia and pediatrics. So it turns out if you kind of nudge someone away from being in the scared zone to being in the I'm comfortable zone, and then we give you the dose in volume so you don't have to worry about that. And now we just say, treat cardiac arrest, treat SVT. And in the class that we've run all across the country, it's all about treating kids the same way with the same emotional kind of pattern that you treat adults. Because once you come in, like you said, scared and you feel incompetent, now you're not looking at people. Now you're not looking at the physiology. Now you're running scared. You're running, you're grabbing and going, diesel fuel. And now all of a sudden the kids get,
Liberal amounts.
right, and the kid's getting worse. And you're just saying drive faster, which is really the wrong thing to do. We know that. So.
I think you're all right. It is the wrong answer, and hopefully, we're starting to, and you're doing a great job of this. Is starting to move trends the other direction, and
Yep.
that's a very good point. How can the provider, the clinical professional that does not have a lot of pediatric experience, what are some quick, just maybe one or two tips that you might have to hey, what can you do to bring your stress level down, guys? Because they may not have your protocols in place. They may still have,
Sure.
you know, their current protocols in place where, you know, they are going to feel inadequate. They may feel, you know, out of their realm or out of their depths, and they're going to kind of get worked up. So what are some things that they can do in that moment real quick to woo-saw, so to speak, and bring it back down to hopefully go forward?
There's one big thing that everyone can start doing today, right after they watch the video, right today, and it doesn't cost anything, okay? And it turns out that what you have to do is before you get to the call, you have to know 3 things, okay? The number one thing is, and again, we want to make believe that every single call you're going on is going to be a cardiac arrest, because that's like what scares people the most.
Yeah.
So if you're going in and you're saying epinephrine, you know the dose of epinephrine. If you know the airway size and you know the joules, right? Just like you would for adult cardiac arrest, all of a sudden you're coming into the case. Let's say it's a 1-year-old, you know it's 1 ml of epi, 1 in 10,000.
Mm-hmm.
You know the eye gel size, that's what we use as eye gel. You know that, right. You know that the joules are 20, right? So now if I can come into a scene where the kid is sick as dirt or even in cardiac arrest, and I could look at the parent, and I'm not looking at any books or tape or app or anything, and if I'm the one who's doing the epi, I know it's 1 ml. If I'm the one who's doing the monitor, I know it's 20 joules. If I'm the one doing the eye gel, I know it's a size 1.5 as an example. So we call it the pre-arrival discussion. So what people made mistake for so many years, and what we're trying to undo, is they force you to get to the scene, and on the scene, that's when they want you to start learning dosing and equipment sizing. In adults, we don't do that, right? You hear 65-year-old cardiac arrest, you're not to the call, you know it's going to be a size 7 this, it's going to be epi a milligram, it's going to be 360. So like we're kind of taking that same information and putting it on the pediatric side. And so the pre-arrival information, knowing the dose of epi, the airway size, and the joules before you get there is the most important thing you can do, so that when you come onto the scene, you have to look at the parent eye to eye, look at them right in the eye, and have that look on you like, we're here, everything's going to be okay, rather than walking in, being scared of them because you're nervous, not looking at them. They start getting amped up, you're getting amped up, and now the kid doesn't get the best care. So it's very simple. This is not so hard to do.
It doesn't seem like it's rocket science, but I will tell you, as being that guy that was in that situation at the time, it was like German or, you know, nuclear physio. You know, it was beyond me, because all I could think about was sick kid, move sick kid to gurney, put kid on monitor, start bagging kid, drill the kid if I can't get an IV, run as fast as I can, turn the sirens and lights on as bright and as loud as they can, and let's go. And let's get someone else to help save me. You know, and I think that's a very good point that you point out, is it's the pre-arrival. Get your head in the game. You know, we talk about the 7 Ps. What's the first P? Preparation. You know, why should preparation wait till you arrive on scene? Why don't you pregame yourself a little bit before you get there? You know, I love that idea. One of the little posts I'll share is I would put a piece of tape on my flight suit, and I would write down, hey, what are normal vital signs? What's the hypotensive systolic pressure I need to look at? What's the tube I'm going to go with? What's my epi, and what am I going to go depth size? And that helped, like you mentioned, disarm me. Because when I got there, if I had to go to a rescue, I had it all lined out.
Correct. And that's in essence what we ended up figuring out, and that's what our class does. Our class just brings people to the point where by the end of the 4 hours, they've totally converted to the other side, because again, we're giving them the dose, you know, and that's what the application does, right? You know, it's a 1-year-old, it's 1 ml of this, it's 1.5 of that, it's 20 of that. You're getting there, and you know in advance, and it's customized to your protocols. So there's nothing anymore about, once we've taken all the information away and we've kind of put that, and we said, we're going to give you that. Now you can say, now I'm just focusing on another kid with whatever etiology of disease you give me. I can take care of that because I've done it a million
times. I've done 20 adults already, you know, like that. It's like, oh, okay. You know, and I know we don't like to call little kids adults, but
I do.
But you mentioned like the mentality, you know, it does, now that you mention that, like it's kind of changing the way I think too. It's like,
we've been fooled. We've been fooled.
They always saw us in paramedic school. kids aren't little, kids aren't adults. They're their own little thing. And peds aren't, or neos aren't their own, they're their own little patient too. But what you're saying is, hey, if you treat everybody the same, you disarm yourself and you end up doing better patient care because you get your brain back, right?
Correct. Well, I met this guy, Thomas Edwards. He's from Aiken, South Carolina, just at EMS World Expo. He says, you know what I'm going to do? He says to me, we're only going to train on pediatrics at my agency because adults is easy and adults is the same as pediatrics. So what if I only train on peds so that it just becomes part of the normal thing of what we do? And so after he came through our class, it kind of hit him. He's like, and Dan Limmer, who writes the textbooks for paramedic training,
yeah,
I spoke to him a year ago, and he said, I saw him at Expo. He said, Pete, I just changed my entire book. I took out the pediatric section, and now in every adult section, there's a pediatric section, seizure, adult, pediatric. So he says, no longer is my book. He changed his entire book. So finally, it's taken us only a decade.
It's only a decade. We know how fast change happens, right? We're going warp 9. No. roll the throttle off. We're just going to see here.
Yeah.
Well, at least you're moving the needle forward, man. That is extremely impressive. And, hands off the Limmer and the rest of those guys for taking it. And that's how you get forward thinking. That's how you get progressive, right? And kind of start changing. And hopefully we start impacting these patient populations in a bigger manner than we were in the past.
Huge.
Great points on how to disarm ourselves. Thank you. But moving on a little bit. So when we talk about bronchiolitis versus croup, what do you for the student how do they assert the difference on scene? Because we know one is an inflammation of the bronchioles, one is more an inflammation of the upper airway, and so, the disease process is a little bit different. So how do they kind of, is this bronchiolitis or is this going to be kind of a croup? Take away the seal bark. Okay. We all get that. That's a hallmark sign, but take that sign away. How did you differentiate between these two?
There's one big thing, and this is kind of my favorite topic, right? Because I'm going to put now asthma and bronchiolitis in one hand and croup in the other hand.
Okay.
Asthma, bronchiolitis, those kids started getting sick this morning, and then by 12 o'clock they're a little worse, and by 3 o'clock the cough is still not going away, and it's getting worse and worse. And if you ask the parent, they'll give you that history of it started and it's just a progressively deteriorating problem unless you attend to it.
Okay.
Croup on the other hand is completely the opposite. Croup, the kid had a little runny nose before bed, was put to sleep at 8 o'clock at night, put the covers over them, everything was fine, and then suddenly at one specific time, 12 o'clock, 1 o'clock in the morning, and so the physiology is important because that kid is an obstructive airway disease, right? Mm-hmm. The CO2 went from 35 to 45 to 55 to 60, and now it's 2 o'clock in the morning. And when your CO2 goes up, your brain gets a little bit like it wakes you up. And if any of us had a CO2 of 60, we wouldn't be acting normally. So the kid wakes up suddenly in the middle of the night, parent runs in, and they see a kid who's kind of like in outer space, like not normal. And now that the kid's awake, the mom takes the kid, holds the kid, and panically calls 911, right?
Yeah.
Right.
Someone come help.
Right. Oh, and if you listen to the 911 call of a croup, sounds way different than an asthma or bronchiolitis, right? So now the kid's awake, and now you're en route, 6-minute ETA, but now they're awake and they're breathing. 65, 60, 55, 50, 45, 40. And then we show up. And now the kid looks great. He's got a little runny nose. The kid's about 18 months old to 3, something like that, usual age for croup. Whereas the bronchiolitis kids, younger usually. But right, a kid with bronchiolitis at 1 year of age and a kid with croup at 3 years, it could be the same virus. It's just affecting them differently. So here's the kicker. Okay. When you walk into the home, if you don't say to the mom, let me ask you a question. Did you put little Johnny to bed at 8 o'clock last night? Oh yeah, everything was great. He was sleeping perfectly fine. And tell me something, right before you called us, did he wake up and you walked into his room and he looked like he was, oh my God, yeah. And then by the time we got here, he's looking fine again. Oh yes, exactly that. That's croup. You don't have to hear the bark. Now, the asthma kid, the parent never went to bed. they've been giving treatment since 12 o'clock noon. And then now they're up to every hour, God forbid, but let's say we're giving it every 4 hours, now every 3, now every 2. It's a different story, right? So if you come in and you automatically just hear a wheeze, because like you're listening or you're listening just by your ears, and you will get fooled if you don't ask the story. So the Croup story is night and day from the bronchiolitis or asthma story. That's the key. And then I would treat it differently. I would give the Crouper racemic, or what we carry is Ep.01, 3 to 5 mLs, throw it in a nebulizer, throw it on.
Okay.
Whereas the asthmatic, it's a beta-2 agonist, albuterol. The Crouper, if it was a bad Crouper, the bronchiolytic, I would not give albuterol to. And because we don't have 3% saline, I would give a racemic or 1 to 1,000, although some people disagree with that, although, there's great data to show that it does help a little bit. So I think that, and then if you really if you're really like not sure which way to go, asthma or Croup, here's the solution. You give them, everyone gets Epi nebulized, because Epi is also a beta, it hits the beta-2. So Epi hits the beta-2 for the.
It's more of a blanket drug. Doesn't matter where they're at. It'll hopefully catch everything.
The best freaking drug in the world. So ever since I added on to my protocols, I can't tell you how many medics of my medics have come to me and said, that was the best freaking thing. And I tell them, if you ever don't know which way to go, even if you ask the questions, Epi, nebulize.
So what you're saying is with Croup, it's more of like an acute event. It's going to kind of light off in a big way, and then that should be your story right there. So going back to that assessment, take a minute, take a step, take a breath. Correct. Hey, mom, what happened? Versus, oh shoot, I'm just going to grab kid and run. Versus, with epiglottitis, bronchiolitis, that's more of a trending deterioration over time, a greater time. So it's not more of an acute event. And then if I could hit on that Epi real quick. You mentioned the dose, but can you just kind of go over it real quick for our viewers on, hey, how would you make this? So you talked about Epi 1 to 1,000. You take 5 mLs, squirt an SVN. Do you add any saline? Just that 100%. There's your racemic Epi.
Yep.
Put it on the SVN.
And I have a great study was done in 1974. And here's the conversion. Racemic Epi comes as this little vial, right? This, 0.5 mLs.
Ones in the hospitals are very, very small.
0.5 mLs. You got to add 3 cc's of saline to it. So all that 0.5 ml is the equivalent of 5 mLs of 1 to 1,000.
There you go.
So where you have to dilute this with 3 ml, you don't have to dilute the 1 to 1,000. So the younger kids will get 3 ml of 1 to 1,000. The older ones will get 5 ml. And it's really, as long as, it really doesn't matter. You can't screw it up. Now, if you gave a preemie, if you took 10 mLs and you gave a preemie, a 28-weeker, and you had them nebulized Epi, I've seen people screw that up in the NICU. But giving 3 mLs to anybody is safe. Older kids, I would give 5 mLs to, because remember, half of it's going to the wind anyway. Right?
Yeah, half of it's going down to the gut. What is your age cutoff for 5 versus 3?
1 year.
1 year. So you're saying less than 1 year old, we should probably go with 3 mLs of racemic Epi using 1 to 1,000. Put in 3 mLs of that, SVN that. If they're over 1 year old, let's grab 5 mLs of that 1 to 1, mix it in. There you go.
And I'm happy to send you the paper.
Simple, and it's a blanket drug.
It's a blanket drug. And if you're going to intubate, and maybe we'll get to it later, the sick.
Yeah, let's lead right into that. Like, how are we going to manage this if we can't arrest this deteriorating airway? And real quick, let's recap on some of those signs. Like, I know that you mentioned earlier about lifting up a shirt. What are some clinical signs that would be astute to a clinical provider going, hey, you might want to start setting yourself up for an airway? Because I know what happens clinically for me early on is I would wait until essentially I needed that airway like 5 minutes ago. Right. So what can we do to set ourselves up or see that train coming, so to speak, so it doesn't just hit us, blindsidedly? Yeah,
I think the values are very important. When I say the values is what are the basics? What's the kid's heart rate? What's the kid's respiratory rate? What's the kid's SpO2? What's the kid's end-tidal CO2?
End-tidal.
End-tidal. So especially
why don't people use more of that? I don't understand. It's such a beautiful, you get so much from end-tidal waveform capnography.
Honestly, people just don't think of it at the time for whatever reason. And so, you know, you just got to keep talking about it around your department, and then ultimately, like seizure, you know, obviously cardiac arrest, but asthmatics, sepsis, right? If the end title is less than 25, that's a marker of a metabolic acidosis, right? Because you have a respiratory alkalosis, which is combating the metabolic acidosis. So it's a compensation. So I think that's important. So once you have like just the basics is important. Now, you want to look to see if there's retractions, obviously. So that's what you've already done when you first walked in the room. And then the mental status is an important one, right? Because where people will get fooled, especially in pediatrics. Remember, these sick kids, they're always coming sick in the middle of the night. Why? Because the parents wanted to go to bed. They've tried to give some treatments. They may have been at the pediatrician and said,
self-care at home, try to avoid going in. It's an inconvenience.
Avoid going in. So it's always going to be a evening, late night, or like early morning, and you're going to come in and you're going to see this kid doing that. Their eyes, right? Their eyes are important. So if the kid who's a toddler who should be looking at you when you come in the room, if 3-4 people walk into a room and the kid hasn't looked at you, and it's 2 o'clock in the morning,
that's one of my signs. Are they tracking me? Because
yes.
they see big me walk in with my bunker gear or my flight suit if I walk into the hospital or wherever. If they're not tracking me or afraid of me, I have it. That to me is okay, something's not right here.
But let me tell you, Chris, a lot of people will convince themselves, because I did this, right? They'll convince themselves that it's just you know what, it's late, and and then all of a sudden you're like, is this mom really telling me the real story and all this kind of stuff? So you really have to kind of like evaluate the child as a whole, look at all the values, look at the numbers, and then put a stethoscope, right? Because you want to see, is there air movement here that you can actually hear? And oftentimes, they have so much air stacking and things are getting worse. And then what happens, people oftentimes forget to look at the cardiovascular status of the kid. And see, here's what I mean by that. And I think all the listeners here should know this, but that negative pressure is doing a lot of things. And most importantly, it's allowing blood to kind of fill up that right ventricle, so that on the next output, you're actually getting blood to the rest of the body.
Yeah, decreasing cardiac output, you basically put a plug in that RV.
Correct. And what happens is people forget the fluids, right? Because they don't recognize how important fluids are. So every asthmatic I see, when I'm coming in, I'm ordering albuterol, I'm ordering salumedrol, I'm ordering magnesium, Heliox, but I'm also ordering bolus of IV fluids. And I give a 20 per kilo bolus, and then I follow it up with another 20 per kilo bolus. Give the IV fluids and give it quickly, and don't mess around, especially because of the fact that if you end up intubating these kids, which is the sick asthmatic, is not a good idea to have to intubate, but here's when they die, is as soon as you paralyze them, right? Because all of a sudden, taking away that negative intrathoracic pressure, and that's the only thing that was keeping them alive. And so let's get back to the epi, the nebulized epi. If it's a bad asthmatic, and I know that I want him or her to have, some vasoconstriction sitting in there, I'll actually start off by giving the nebulized epi. I'll do an epi-IM because I want to, and then I'll have the push pressure epi ready as well. And then if you want to even move into this, I've moved to DSI. I've abandoned RSI. And this is thanks to people like Scott Weingart, Jeff Jarvis, Jeff Jarvis, my hero, who basically kind of said, hey, wait a minute.
Those guys are everybody's heroes, just like you are mine. So it's okay.
Yeah, but
we're all happy.
Yeah, exactly. But a guy like Jeff said, hey, not only am I going to do it, I'm going to publish on it. I'm going to change the world. And so I initiated an RSI program in my agency, and we had 15 cases. It was going great. And then his paper came out. I go back and look, and I see how many cases that had peri-intubation hypoxia. And so in this particular case, especially with the asthmatic, here's what I say now. We say delayed sequence induction. So we're doing everything we talked about already, but now we're actually going and giving ketamine. So out of all the drugs we just added up, So now we have someone holding a two-handed BVM with PEEP, okay? So now when you give the ketamine, the patient's not going to fight you anymore. It's going to bronchodilate them. And now you're holding the bag, you're not squeezing it, but you have 5 of PEEP on there. And now the patient's breathing in, you're able to kind of help open up their airways so they can expel the CO2. And now, if the patient gets better without having to intubate them, hallelujah, we're done. Okay? So ketamine,
that's what we're trying to shoot for, right? That's what we're going for.
Right. End title's coming down, sats are coming up, worker breathing is getting better. I can start to hear something. Right. So now, now we look at the blood pressure, because we know that any episode of hypotension, especially in an asthmatic, they're going to die. So we have push pressure epi ready. So we take the 1 in 10,000, we take 1 ml of that, and we add 9 mLs to saline. Now we have epi 1 to 100,000, which is 0.1 milligram in the 10 mLs, right? And we do 1 ml and we stop. And we watch that pressure come up. So now we have IV fluids on board, and we have that push pressure epi, which is kind of vasoconstricting, giving my RV some more fill. So now when I eradicate that negative pressure, hopefully I'm going to have a patient who actually doesn't lose all blood supply and then just dies, right? So
yeah, hopefully that doesn't happen.
Right, but those are the kids that it'll happen to. So here's what I also put into the protocol. If you give the ketamine and you have to intubate, I allow them to try an awake intubation. Awake meaning without paralysis.
Without paralysis.
Right. So they're out.
Is that that's just mainly on pediatric patients, correct? Because we would do that all the time flying. Or you do know with the adults too?
Oh yeah. Because they're again, I have a protocol which is a beautiful protocol that treats kids and adults the same way. There's no separate section. So whatever we do for kids, we do for adults. I just started finger thoracostomy thanks to the people in Texas. I'm doing what they're doing. Kids and adults, the same thing. So the sick asthmatic is one of my favorite topics. And I think that we all kind of need to know the physiology of where and how they die. It's not just about the albuterol, it's about the cardiovascular system. It's really the key.
It's the cardiovascular class, which I think a lot of people, they get tied up or tunnel vision into the respiratory problem, that they forget that all that interthoracic pressure is just causing your IVC to get smaller and smaller and smaller. And then, hey, here's a paralytic on top of that.
Correct.
You know, and I like your kind of conversation of resuscitate before you intubate. So give them some fluids, give them a little bit of push dose epi, give them some ketamine, give them a little just PEEP, you know, to open up those alveoli, allow that more gas exchange so they don't get in that acidotic, you know, metabolic collapse and code arrest. Stave that off, get cardiovascular, you know, preload to help with the RV. And I wish it sounds simple, right? The way you explain it, it's so simple to me.
Let me tell you, we're here, what is it? We're in October 2019. Yeah. I guarantee you walk into a hospital in October of 2029 and they'll still be doing RSI. They won't be doing DSI, because the resistance of, especially on the hospital side, of telling people, hey, you should do DSI, get 3 minutes of 94% O2 sats or greater, get the nitrogen washout, make sure that when you're looking that your O2 sat's not going down to 20%, doctor, but they don't do that. So it's sad to say that what we're talking about today, just like what I've been trying to do for the past 10 years, is finally coming to fruition. But simple things that Jeff has published on, it's going to take a long time.
I know. Bad medicine just seems to perpetuate itself for a while, unfortunately.
That's what people like you are doing, just getting the word out, and hopefully somebody out there will say, hey, maybe that data is something that I should look at. So
I would wholeheartedly agree. And I'm a big fan of evidence-based medicine, because it's like the numbers don't lie. You can't fudge numbers. You can't skew them. I mean, obviously you can if you put them in wrong, but you know, numbers, they tell the truth, you know, at the end of the day. And so
especially with intubation, it's cut and dry, right? It's basically, did you have a hypoxic event or hypotension at any point during this RSI sequence? If the answer is yes, then that's a problem.
Yeah, the mortality rate goes up, and we know that. You know, and I love how you hit on the whole point of, you know, whether it be asthmatic or, you know, your Croup or your bronchi, if you're trapping CO2 down, right? And we know what their physiologic compensatory mechanism is going to be tachypnea. I'm going to try to breathe this off the best I can until I can no longer do that. And then obviously that's when it becomes a problem. I think a lot of providers fail to remember when they're in that whole, in that high stress environment to, hey, I got to go and I have whatever they are breathing at, I need to match that or even go above that because they probably were breathing faster if they could, but they became respiratorily fatigued and slowed down. And then we come in and I see that pediatric patient who was breathing at 36, 40, 42 a minute. And I go, oh, I'm going to breathe you at 24 or 30. And what happens during, and that's also during that RSI period where, great, now you've taken away the paralytic, you've administered the paralytic, increase that intrathoracic, take away the cardiovascular output. And on top of that, you're going to just totally put them in metabolic acidosis collapse.
Yeah. And that's why we have a checklist, which I'm happy to share the entire folder. We have a checklist.
I would love to. Yeah.
Yeah.
We'll attach this to the show notes for sure.
It's got all my PowerPoints. It's got the checklist, and it's very slow. Like you're sitting there for 3 minutes, and you're with a checklist, and you're actually making sure that you're hitting all these points. What is the end title? What is the waveform capnography showing you from a respiratory rate? Because once we intubate, we're going to match that rate. So after the ketamine, you get like a native rate because they're relaxed and now they're just breathing at the number that their body needs to breathe at. So if that number was 40 before, we're going to do 40 after. And then the other kind of tip that's very important in asthmatics, what bothers me, my pet peeve is they all come in with a non-rebreather. Asthma is not an oxygen problem. If you're hypoxic,
it's a CO2 problem.
Right, but if you're hypoxic and you're asthmatic, you're sick. I mean, you're at the bottom of the drain there. But I actually, every time I see an asthmatic with a non-rebreather, we rip it off. If you come into my emergency department when I'm treating a sick asthmatic, we go off of room air, because if that asthmatic is SATs are 85%, I want to know that. So, and if it is, I'm giving them a nasal cannula, and I'm giving them whatever O2 they need, not to slam it in, but. People focus on, asthma, oxygen. That's wrong. So we have to kind
it's
of
not a hypoxic problem.
No.
It's a hypercarbic problem. It's not getting O2 in. They can get O2 in those, no problem.
All day long.
They come back across the pulmonary capillary beds and get out of the lungs. That's the problem.
Which brings up another point, which if you talk to like the younger medic or the paramedic student and you say, we're going to give CPAP, right? Try CPAP in the awake patient. And they're like, but wait a minute, if they're having trouble getting air out, why are you giving them CPAP? So I think it's important.
I always get that question in my course. So yes, let's just touch on that real quick. Why do we use PEEP when someone's awake and spontaneously breathing still versus when we first freshly intubate them and we try to use more of a ZEEP and then transition back into a little bit of PEEP?
Right, you want to stent those airways open so that when they're exhaling, so at a PEEP of 5 as an example, you're keeping the airways open so that when they're exhaling, they're actually getting the CO2 out. Obviously, turn it up to 10 or 15, you're going to cause a problem for that patient because it's hard to breathe against that. But actually, you give them a PEEP of 5 and they feel better and they can breathe better. So there are things like that are amazing physiology that we just have to talk about and keep talking about, because people are just kind of they're what we call a protocol medic, where they just come in
cookbook medicine. That's what it is. I've been trying to move away from cookbook medicine. That's why I love my medical director, both at IAMED and Classic, is Dr. Mike Hudson. He's a very progressive guy. Hey, you guys, we hired you for your brain.
Correct.
Use your brain and critically think. These are guidelines. Okay, these are to help kind of guide your thinking into what you need to do for that patient.
Correct. And that's why I actually give my medics a lot of leeway that in our DSI sequence, if you want to hold off on the rock, fine. If you want to throw an eye gel in, fine. If that doesn't work and you got to paralyze and throw an eye gel in, fine. But there's no perfect algorithm. No patient follows the perfect algorithm, and you always have to keep your eye open for all the physiologic markers that that specific patient may have or not have. And so you have to be really attuned to what's going on physiologically for the asthmatic in this particular case, rather than just kind of blanketing everyone with the same exact.
They say they're all in the same kind of thing. I think it goes back to like that famous saying with the ventilator. You're trying to tune your patient to your protocol versus your protocol or guidelines, whatever you want to call them, to your patient, and critically think down that road. are there any quick airway pearls, you know, if I had to mitigate, you know, whether it be a bronchitis, epiglottitis, or croup patient, if I'm setting up for an RSI in most people's cases, let's just be honest, or a DSI, when it actually comes to game time, you know, what about like positioning, ramping? What are some things that might help them clinically be successful with managing that advanced airway?
That's a great question. I think positioning is the key. As we all know, the kids, you know, the kids who are younger, who have the big occiput, and then you lay them flat and they do one of those.
Yeah.
Right.
I had
You
a
do
great
one of
little
those.
video I shot by my campfire, my son who actually had croup. And what I did
Ah,
is I had him, he was laying in my arms out by the, you know, out by the fire while I was having a whiskey one night, you know, and I just got a hair at my butt because I was like, this is a great demonstration. So he was hanging there just doing that storing respiration, a little bit of croup. And I was filming and I literally just pushed up on his shoulder blade to cause a little bit of opening. Nothing. He's breathing just fine. You know,
right.
it's just that little aha moment that I think people need.
Yeah.
Positioning with these little kids is absolutely, you know, paramount.
And also, you know, how to do a jaw thrust, right? And then also,
Basics.
there's another one where people will put their, you know, they're holding the bag and their hands, their fingers are in the submandibular space and they're pushing back against it. A good buddy of mine, Dr. Mark Peel, who he's the guy who created that Life Flow, that kind of like it's like a little device that helps you get fluids quickly.
Yeah,
He's a
yeah.
pediatric ICU doc. He actually went a kid who's having stridor in the MRI machine. He crawls in and he actually just did a quick jaw thrust in the
Forward.
machine. Yeah, exactly. And you can see on the MRI, the whole airway just opens up. So a lot
They
of
had that
people,
on MRI. That would be an awesome MRI
on,
to see the
it,
change.
you see the change. No, he got the two MRI pictures. And
Oh, that's
so,
awesome.
right. So just basically knowing how to hold the BVM is a very important skill. So, and then we'll talk about positioning. So of course, you know, how many people don't know how to get that's the sternal notch, you know, the tragus to the sternal, to the front of the shoulder, in the what Jeff Jarvis calls the beer sipping
The
position.
beer tip.
Right.
Hold my beer.
Right. And so, you know, having the patient, you know, let's say at a 30-degree angle, which we also know is important. So I think when it's game time, you have to know how to prepare. You have to be ready for everything, right? And so you can't just have your ET tube out and not have your rescue airway available. You have to know if you have to, like you had to needle crike somebody, if it's a younger kid. You have to know where that stuff is. You can't be scrambling for it. And the beauty of DSI is that the checklist goes through everything, and it says, make sure that you have all these things. And you have 3 minutes of O2 of 98%, of 94% or higher, plenty of time to get everything ready. Suction is a big one, right? And a lot of people now have kind of switched over to the decantos, and we're learning salad and stuff like that. But in pediatrics, you have to suction, because how many people go in, they look, and they say, oh, I need suction,
Yeah,
and then
and
they
it's
get
not even
suction,
on.
and now, right, it's not even on, and
My
now,
suction goes right underneath the right shoulder, so it's like, hey, I'm in there, I need it. Okay, I take my bougie out, take my suction, and most of my kids, no offense, in my clinical practice, I don't know about you, maybe you can attest to this, but it seems like kids, almost all my airways and kids have had to have suction first
first.
prior to actually doing the airway. Like every time I open it up, it's like they always got sputum back there. They're copious
Put it
amounts. My
in.
son is always seems like he's heating or he's just drooling everywhere.
Just put it in before you look. Like,
Yeah.
why are we putting the suction in first, right? So I think that just some basic things where you know you're going to need it. Make sure you have it ready, and know how to use it. So I think so. We've talked about preparation. We've talked about placement of the airway. We've talked about basic airway maneuvers. Oftentimes, you know, people won't use the airway adjuncts to their benefit. I think it's a big one. Video
You know, I
laryngoscopy.
just saw that in a
Right.
recent case. You know, where
Okay.
they orally dislodged the tube, and what ended up happening later is that there wasn't a failure or transition to actually placing an OPA or MPA, and so you're literally trying to ventilate that big tongue that's already occluding. So all that air is going right here and coming right back out the nose, and you're fighting yourself, and some of it's
Correct.
going in the gut, causing gastric insufflation, and you know it sucks. But no,
The
that's a very good
question,
point.
The question is, do you know where that equipment is? Do you know what size it is? All of a sudden, when you're in and someone needs a 50 millimeter OPA, so where is that? All of a sudden, it's a problem. So all these things, like you said, if it's game time, these things don't happen in an instant. If you know you're going to intubate somebody, you probably knew that ever since you got to in front of the kid, or you've known it for the last 10 or 15 minutes. And
Agreed.
so getting everything ready, prepared, and then having the right equipment. So for example, video laryngoscopy has really changed the game for a lot of people. So I think that's important. But there's data actually from Air Methods. They just came out with something. Dave Olvera just published a paper as an abstract showing that people have the most difficulty with infants, right? Because the anatomy is different, the airway is more anterior. Again, the head is different. You have to use a different blade than you've ever been used to using, and so I think that it's not really that difficult, but it's all a mindset and just kind of knowing how to do these things when it comes time for game time.
Yeah, I think you're great, and you're right on that. I think when the provider has to go to something they're not used to and they don't use on a daily basis, it just totally changes their thought process. And I think that could go back to training. What did you do to prepare for that game day? Guys and athletes don't just show up on game day and play. They practice, they train, they dedicate themselves to improvement and self-improvement before game day. So that way when game day happens, when stuff goes wrong, what's the first thing you're going to rely back on? It's going to be your training and your education, because I can tell you, for me, like when the wheels are falling off, I go into muscle memory. I just start doing things and I'm just like, my brain knows what it's doing. Okay, cool. I'm just along for the ride here. But that just comes back to all the training that I've done. And I rely on that to get me out of that situation, or at least give me a buffer zone where my brain can come back online and I can connect it to.
And that's why you should have your protocols similar for adult and pediatrics. So for example,
you definitely have intrigued me on that. And I'm definitely going to go down that route. I'm going to talk to Hudson about that.
It's a must, and I'm happy to share my protocols. Like an example, cardiac arrest. If you're a kid or an adult, in my systems, you get 2 big breaths, and you get an eye gel. Everybody. That doesn't matter who you are or what you are. We can upgrade the airway later on if we get ROSC. But we aren't intubating everyone left and right here. We're doing the basics of eye gel, supraglottic airway, and then moving from there.
You know how hard that train of thought is to change? Just go to oxygenation and ventilation. Hey guys, you really don't need to put a tube in. Like, yes, that is a definitive airway, but right now at this very moment, more than likely you're going to have a higher success rate grabbing an eye gel or a king or something to provide oxygenation and ventilation versus, hey, I'm going to wait and do a BVM and I don't do it correctly. I don't position, and then it's just that spiral kind of down.
What you need in cardiac arrest is, great BLS. So if there's any BLS people out there, all the ALS stuff we do is BS.
5. Save our butts. keep teaching us and reminding us about, hey, don't forget the BLS before you run forward.
It's all about the BLS, baby. And, for example, when you have people who are, let's say, cops who don't recognize that they ought to be in the triangle, right, in the pit crew, just as well as my medic should be. And if you're a firefighter and you work in a system where the paramedic is, let's say it's tiered response and the paramedic's coming after you, just because the lieutenant gets there doesn't mean that you now leave. No, you own that patient. You should be able to do CPR just as well as anybody else and do it the right way. So it's all about BLS. Adult kids.
I hands down agree with that. It comes back to doing the basics before you can go forward. Like if we do really good basics, what I have found is along with the new adjuncts that we have, like high flow and stuff like that, we're not having to go down that intubation route, which we know just by going down that route, we increase their mortality rate. They get a tube, we increase their mortality rate. If I can prevent those 2 things from occurring from the start, hopefully I can stave off the downstream effect. Some patients it doesn't work in. But there's a lot of patients that I've found lately that I've been able to steer them off that clinical course just using good basic maneuvers.
100%.
So to close this all out real quick, and this has been a phenomenal talk, by the way, what are some your medics, what are some documentation keys, that you would kind of put forward with, hey, this is what you like to see as a medical director, or, hey, let's just change this a little bit. as someone coming in to give you a report, what are some things that you want to know right off the bat? Like, hey, this is the key points that maybe we should be getting across a little bit sooner.
Listen, I do medical expert work, and I can tell you that the biggest deficiency that I see in the hospital record, the EMS record, is always the documentation. So what happens is that if you're going to get called out on something, it's not going to happen the day after. It's going to happen a year later. You may find yourself in court 2 years later. You will remember this much of your call. So you have to document it the right way. So I hear from my medics all the time, well, I already put it up in the chart. Why do I have to repeat myself in the narrative? And you know what? You don't have to repeat yourself, but the narrative should tell the story, and the narrative should tell a very important story. And you have to kind of be able to express your medical decision making and why you did what you did or why you didn't do what you did. So stating that you did a full assessment, stating that you reviewed all the vital signs, especially if the patient is going to be a refusal. So I think that from the documentation perspective, I think that the narrative is a very, very important part of it. And if there are people out there who think that the narrative should be one sentence, I disagree. And as the
agree, I see those all the time. It's painful.
It's painful. But as that patient gets more acute, and especially when it's a one of those refusals that you know it's a high stakes refusal, your narrative needs to get longer. You have to put all the right wording in there, and you have to kind of do that right. Where I also see people make mistakes is that they kind of they're putting in data into the EPCR that's not accurate. So how did I find that out? I know that if I see a time on the EPCR that says like 12 o'clock and 11 minutes and 00 seconds, the 00 means that they kind of just put it in after the fact. So we see people who are in a cardiac arrest, it's zeros.
It just kind of befuddles me that people don't realize that. Like, we know this. Like, lawyers will look at this. I mean, medical experts will look at this. You know, when I get consult for a case, I look for that stuff. Like, I'm glad you brought that up, because it shows that, hey, you probably just pencil list this, or you weren't as maybe, in depth as you probably could have been.
Right. And I think that everyone needs to go through like a mock depot. If you're a young paramedic or you've never been through one of these, you realize that it's a jarring experience for people. It doesn't feel comfortable, and it makes you recognize the importance of that medical document. Now, when I'm getting a report from somebody, it's just very, very important that it's very succinct. This is who the patient is. This is what I think is going on. This is what we've done, and then to get a handoff. But I want to see someone who's synthesizing the information, who can give it to me very quickly. I'll give you like a doctor example of this. When I call a surgeon, I don't start by saying, hey, yeah, I got a 3-year-old. He came in 2 days ago. He's been here for 12 hours, but he's had pain for 4 days. The surgeon is thinking, why did you call me? So it's, hey, I have a 2-year-old. I'm concerned about appendicitis. He's had pain for the last 12 hours. He's been vomiting. I did a CBC. It's elevated. We have an ultrasound that's positive. I need you to come in. Boom, done. So like
that paints a nice, clear picture.
And I started with the problem. Hey, yes. I have someone with boom, and then I prove my case with all the pertinent positives and the pertinent negatives. So I recommend to all the people listening, when you're giving a report to a physician or even getting a report in general, start with what you think that it is, right? And then explain why in the history part, the physical exam part, and then you're done. And then here's what we've done. That should take maybe 2-3 sentences maximum to do it effectively. Obviously, if it's a less sick patient, you can go into more details, but always start off with, hey, doc, I got a 2-year-old I think is an asthmatic. Or here's a 3-year-old I think he's got croup.
I think he's asthmatic going into respiratory failure. You're like, that is a key to that. To me, if I'm that doc going, okay, you're on it, versus, hey, I think he might have asthma or he's having difficulty breathing. Like, that's a different train of thought, I think, from you as a clinician, or even me getting handoff from another EMS provider or facility provider. I want to know, like, what's the big bag and ugly? Like, don't tell me
Correct.
that, because then I start disarming myself. Like, okay, maybe this isn't that bad. And I walk in, I'm like, this is bad.
Right, right. Or a kid, let's say I have an 11-year-old who I think is having a stroke. Now I'm going to be paying attention to everything you say after that. Is I want to see how good you are at explaining to me why you think there's having a stroke. Or I think this kid is septic. When I have an ER full of kids who have fever and tachycardia because they're febrile and tachycardic.
Everybody's septic now.
Right. But now this kid, you're telling me you think is septic, and this is why, right? So that's the kind of reporting that you need to do that is different than the narrative, right? The narrative is a legal document that I think 100% of those records have to be reviewed by someone in the department, someone higher up. But then switching over to the reporting at the bedside, that's a skill in and of itself. And I think that once you learn it and you learn how to speak hospital language, I think it becomes pretty fun to get the feedback.
It gets a lot easier, but it comes with, I mean, heck, I mean, we practice 10 radiant reports, for all my preceptees. I'm like, okay, here's your patient. Give me a report now,
Right.
practice. You got to practice, like get on your cell phone and call me so you get that natural feeling. But no, I think those are very good points to help keep us out of trouble. Hopefully later on, should there be an adverse effect, or, should it go to a medical legal panel, it could help us out. But no, I just want to say thank you again, Dr. Antevy, for all the information you've shared during this video cast and IAMED's first live event. So, we're extremely humbled to have you on. I learned a lot. Hopefully the guys that are going to watch this, the guys and gals are going to watch this, are going to learn a lot, take away some good clinical pearls that they can put into play in practice on their very next shift, and go out there. And it's not much, we're not saying much suctioning, positioning, these little things, prepare yourself for what you're going to walk into, and just treat it like it's going to be the big bag and ugly. So when you get there, if it is, great, you're already prepared for it. If not, then great. Now you can take it down to DEFCON 2 and keep rolling down. But no, thank you very much, sir, for your time. I sincerely appreciate you being on IAMED's first live episode, and thank you. If you have anything in closing, please add in.
And listen, I really appreciate coming on. I love these. I love foam, and I love what you're doing. And I think people like you who are out there to change the world, and if you could change one extra person, if our conversation today helps one child out there, as a parent, I have 3 kids, and you got kids, and they mean the world to us. And I think that what we do every day, we're very blessed to do. And we don't treat diseases, we treat people. I think if you can keep that kind of as the North Star, that at 2 o'clock in the morning when you're on your 13th call and you kind of over it already, that person you're going into really needs you. And I think we have to take our profession very seriously. And that's why if you ever want me to come back on, I'm happy to do it. Thanks for the invite. Thank you so much.
Would love to have you back. We'll talk more, but thank you so much, Peter. And yes, please, guys, when you guys are out there, remember, these are people. These are human beings. We all get to a stage. I know I went through a stage where I was kind of burned out, treat my kind of patients kind of like they were human cargo. I'm not going to lie. I'm going to be honest with it. But what I have learned since then is empathy, being empathetic, treat them like a person. And we show through studies that does help with good outcomes. So I love how you kind of tied that in at the end. So
because you were a patient yourself.
I was. And I've been there. I know how that feels to be abandoned. I know how it feels to not be treated appropriately when it could have been better. And and that's why we're in this business, to hopefully help other people improve themselves and do better clinical care. And I'm humbled to have the opportunity to do so. So thank you, Doctor.
You're doing an amazing job. You're doing an amazing job.
I appreciate it, sir.
All right, take care.
All right, guys. Well, thank you for joining in on the IAMED Live channel. We appreciate you guys jumping in. Check out next month's episode coming soon. Stay safe.